So please do feel free to speak up, but there'll also be some time for questions at the end. I'd love to make it as interactive as possible. As mentioned, I'm a clinical geneticist, but I guess I increasingly think of myself as someone who is here to try and help families who are living with rare diseases. And diagnosis is what we're focusing on today, and how we might be able to shorten the diagnostic odyssey for those living with rare diseases. But a diagnosis is really only the start of the journey. And also for many families, a diagnosis is never reached. And so I think it's also over this series of presentations, we're thinking about that whole of life care and that interdisciplinary care. And that's why I think it's so fabulous that we've got many different health professionals from different disciplines that are joining us today. I'm also increasingly involved in some undiagnosed disease pathways, and I'll talk a little bit more about that. So this is what I'm hoping to cover today. Now, the first bit about what we're meaning about the diagnostic odyssey and what the impacts of that are for families. I think I also wanted to not spend too much time on that, but highlight that going alongside these sessions, there are these e-learning modules which are hosted on the Medics for Rare Disease website, and I'll put a link for that in the chat. But for those of you who haven't yet had a chance to have a look, we're now up to lesson 5. So the last one that we released was on the Diagnostic Odyssey and diagnostic tools. So it goes into a little bit more detail what I'll be talking about today. And then the next lesson will be on genomics, and that will mirror and be out in time before our next ECHO session. And in fact, we're actually hoping to get all of these e-learning modules out and ready for Rare Disease Day, which is the end of next month. So more to come, and that's a little QR code to get you straight to there. So really, when we're talking about the diagnostic odyssey, that's a phrase that resonates very well with people with rare disease, because we know on average in Australia, it takes a person over 3 years to reach a diagnosis with a rare disease. But in many countries and for many individual people, that journey is much longer. And people with rare diseases frequently report over that period, they'll have misdiagnoses and inappropriate treatment and be passed between specialists. So in Australia, 4 out of 10 will see more than 6 specialists before receiving a rare disease diagnosis. And many reflect back that over that period, when they don't have a diagnosis, a name to explain their condition, they're often having their lived experience denied or not listened to. And I'd really encourage you to go to the Rare Voices Australia website. So for those that don't know, Rare Voices Australia is the peak national body here in Australia for those living with a rare disease. And so you can go in there, and in their personal stories, which is within their news and stories section, you can see more and read more about people's experiences. And I think that's really important to reflect on that and be guided then by that in everything that we do. So this is what we often talk about, is this medical ping pong where people go between different specialties, maybe started on the wrong types of treatments, new symptoms come along, and it's backwards and forwards and backwards and forwards. And honestly, very frustrating for everyone, and living with a huge amount of uncertainty over that time period. As I mentioned, for those we do get a diagnosis for, that means we have knowledge about the condition's natural history, prognosis. Hopefully as healthcare practitioners, we can better manage the condition, better support, connect people to specific support groups, and help people plan for the future. But often it doesn't take away all the uncertainty. As we know, most rare diseases don't yet have a targeted treatment or a curative therapy, and often the natural history is unknown, as these are very recently described conditions. In previous sessions, and particularly if you go back to our Project ECHO website and have a click on the first, on our schedule, and this is the summary of the first session that we did when Nicole, who's the CEA of RVA, presented, we talked about this concept of family genes. So it's really a mnemonic to try and help us think about which of our many patients or clients that we see may have actually an undiagnosed rare disease. So how a way of sort of grouping or clustering what we're seeing and putting that together. And there's a little fact sheet that we did on that, so you can actually download that PDF, and I have that up on by my computer when I'm thinking about patients. But I always think it's easiest to actually work through a scenario, and I'm very grateful for this family who had consented for publication and for presentations on their situation, actually very keen to share the journey that they had. So in this situation, I, as a clinical geneticist, was referred this little baby after they'd been born in a peripheral hospital after a pregnancy that was routine care, thought to be uncomplicated. There was non-invasive prenatal screening done at 12 weeks, and the family were reassured, and the 12 and the 20-week scan, no significant concerns were raised. But the delivery was complicated. When the baby was born, they struggled to breathe, unsupported. They had recurrent apneas. They were floppy. They had low blood sugars. And really, the pediatrician and the nursing staff on the ward and the midwives after the baby was born could see that there was a combination of distinctive features about this baby that was different to their family members. In particular, little jaw, sparse, curly, sparse hair, long eyelashes, and very small nails, which is what I'm trying to show here. Also, as the baby was trying to be intubated, it was noticed that they had a cleft palate, and on follow-up imaging, they were noted to have an absence of the corpus callosum on their brain scan, so an absence of the connection between the two sides of the brain, and also on a heart echocardiogram that there was an atrial septal defect. So if I put that baby into family genes, there's certainly no pertinent family history, but they tick a lot of these boxes. And I think I was certainly not the only one that was thinking this individual could have a rare disease. And that's why they were referred to me as a diagnostician, a clinical geneticist. But what do I do next? What are my next steps in trying to put all of that together and think how I can best help? Well, in that whole story that I told you, what I try to do is think out what are the most distinctive features about this little baby, this little person, because there's many babies that are born that are floppy and have low blood sugars for thousands of potential different reasons. But there's some very distinctive things about this individual that in genetics, we talk about distinctive handles or diagnostic handles. So they're things to kind of like these fancy handles on this picture that are quite distinctive and unique, and hopefully trying to give us some clues to what a diagnosis may be. And because we all describe those in different ways, there's actually now an international approach to try and describe those clinical terms in a standard set of ways called Human Phenotype Ontology, HPO. And in fact, each clinical feature has a number that goes along with it. And the benefit of that is that we're sort of sharing the same language, but also that we can use these to pop into some new artificial intelligence tools that can help us try and narrow down on the diagnosis. So this is one, and I just wanted to show you how it works. So it's called PubCase Finder. It's just PubCase Finder and this, and I'll put this all in the resources. So you can start typing a feature for your patient, and it will actually do a really clever thing and search and work out what the HPO term is, and then you can check on that and add those in. So as you're going along, and hopefully what you're seeing I'm doing is thinking about the most distinctive features of my patient and putting them into this search engine, not doing my spelling very well, and then getting a collection of HPO terms back. And then what I will do in a second is I'll let it search for me and see what it comes up with. Now, PubCase Finder, you might notice, is a search system specifically for rare genetic diseases. Of course, we know that many rare diseases are not genetic, and the next search engine I'll show you also looks for non-genetic causes. So this gave me a differential, and then it also gave me lots of resources that I could go to and read more or look at pictures and compare back to my patient and see which I thought was the most likely as a kind of differential diagnosis. So then if I go to the next slide, what I should be able to show you is the next one, which is called Find Zebra. And this is the one where it doesn't just include genetic conditions, it has a broader remit as well. So very similar, you put in the terms, it doesn't do the automatic HPO search. So you've kind of got to think a little bit about how to phrase the terms, but it is very clever. And if I put absence or hyperplasia, it would still give me a differential list. So here I've just started putting in some of those terms and I'm going to search soon. And again, what it's going to give me is a differential diagnosis. And it actually goes down and I can look, and quite nicely it gives me a list of genes, and that can be very helpful when I'm ordering or might be thinking about a gene panel. I want to highlight to the laboratory what are the particular genes I want them to focus on. So the next steps as a diagnostician, just talked about this, the pediatrician had actually recognizing this child was likely to have a rare genetic condition, had ordered a chromosomal microarray as the baby was being transferred. That came back without a clear-cut answer, referred to me, and I did not know precisely what this child had. So I went for a rapid test of testing both parents and the baby for trio exome sequencing. But when I gave my request form to the laboratory, I did try and highlight those diagnostic handles to help them in their interpretation. So the two things go together. It really helps the power of genetic testing if you've got some guidance on what people are. And this came back as the diagnosis. It was a type of Coffin-Siris syndrome caused by a change in the SMARCB1 gene. And this actually came back within a week of us ordering the test. So we could sit down with the family, connect them up with the international support group, which mum contacted that very night. And by the next morning, she was already in contact with 4 families. We could get proper integrated care, and I could give the ICU team management guidelines for gene reviews. In terms of referral pathways, if you are thinking about how to get to a genetics service, I'd recommend, first of all, because every state, every area in each state is different. If you go to the Center for Genetics Education website, they have this genetic service finder. You can put in the state where you're in or the postcode where you're in. It gives you your most local genetic services. And then if you click on those links, it will tell you how to refer, what their email address is or their fax number and what their criteria are. I think in Australia don't do very well in clearly showing you pathways for non-genetic conditions, but soon to be launched is the Rare Awareness Rare Portal and from Rare Voices Australia, and that will give you some additional support about referral pathways for non-genetic conditions to expert centres. And for those without a diagnosis, I think it's very important that we continue to provide person-centred care based on their symptoms, emotional and practical support. There are undiagnosed disease, sorry, I spelled wrong, pathways, and I'm very happy to tell you a little bit more about that if you've got questions. But also there are support groups for families without a diagnosis, including SWAN Australia and the Wilhelm Foundation internationally. I think to get diagnoses for rare disease and shorten that diagnostic odyssey, we have to think of as a team. We have to take all the support we can get and very carefully go and often revisit history and examination and really listen to our patients. You may not know what the rare disease is, and with the advances in our diagnostic technologies, often it's just really the first step is knowing is the possibility of a rare disease. And that you've got these extra resources that you might now like to have a play with. So that's the end of my presentation. I'm very happy for any questions that anyone may have.